Our new cultural morality primarily views subjective emotional experiences as sacred, above reason. My position is that this neurosis within the field is causing an explosion of untreated cluster B pathology in society because these people are in need, they are needing, by the way, to subordinate their emotional exacerbations to rational cognitive processes. In order to properly treat personality disordered individuals, morality and ethics must be a mainstay of the therapy. This basic position is echoed by many other profound experts in the field, like Kernberg, Yeomans, Clarkins, etc. My contention is that modern society has veered so far toward gratification that individuals are not being treated properly. This is a disappearing skill to treat borderline and narcissistic and generally cluster B individuals. Those asking for data on this assertion are asking for measurement of the obvious, in my opinion. Since Carl Rogers developed the so-called client-centered treatments and Heinz Kohut revolutionized the field of psychoanalysis away from Freudian drives and toward affectivity as the central focus of therapy, due in some part, I think, to an increasingly distorted understanding of Kohut's framework, reason and health of interpersonal conduct have been reduced in terms of clinical focus. Moreover, it has been my experience, and that of countless other analysts, that patients often arrive to our offices because a prior therapist simply empathized with them endlessly, and no other clinical aims occurred. In other words, nothing happened. Those are actually the words of many patients arriving at my office, and I'm sure at many of yours. Clinicians captivated by the distorted view of empathy as an overly maternal, endless gratification unfortunately reinforce pathological narcissism, a key component of all conditions and diagnostic sectors of cluster B, I might add. Some clinicians mistakenly view empathy as an emotional connection. It is not. Instead, it is a cognitive understanding and recognition. That's an adaptation from Charles Brenner. Gratification versus restriction, normal versus abnormal, good and healthy versus the opposite, these all hinge on morality in a sense. A society-wide shared sense of morality is an idea that has been voraciously attacked by our politics and our social movements, I think largely left-wing in nature, but not exclusive to them. And this has been to the detriment of patients needing proper care. So what is morality? Well, it's very simple. The Oxford Dictionary defines it as principles concerning the distinction between right and wrong, good and bad behavior. Of course, it makes no parameters, and I'm quoting Richard Craden here, around what in fact is right or wrong. And this is a conundrum for the modern clinician who has been enveloped in what I would call the postmodern deconstructionist mindset of morals. Modern clinicians are terrified and hesitant to impose their view of right and wrong in therapy. This goes against the very foundation of treatment of severe personality disorders, by the way, which includes the protection of the frame of treatment against their envy and attempts to destroy it. If you don't want to engage in the Kleinian way of thinking, not my name Kleinian, Melanie Klein, as I'm clearly doing here, you can consider the fact that these erratic and diffuse personalities need to be contained through certain guiding principles. And unlike the original Freudian maxim or aim, which largely included an attempt to free the individual from the moral restrictions of Victorian society, not least of which were anchored in their neurotic tendencies, modern society has become rather anti-Victorian. And so the pursuit of treatment does need to shift to reflect this change. Moreover, we might say that Victorian-era society was a real problem for cluster B personalities with its emphasis on propriety. Current Western society is much more accommodating to their inclinations. You could work in Brandschaft's pathological accommodation here quite nicely, I think. To put this most succinctly, and to borrow from Craden again, modern psychotherapy has a neurotic avoidance of addressing a patient's responsibility because it views doing so as sacrilegious against supporting the patient's so-called authenticity. Our new cultural morality primarily views subjective emotional experiences as sacred above reason. My position is that this neurosis within the field is causing an explosion of untreated cluster B pathology in society because these people are in need, they are needing, by the way, to subordinate their emotional exacerbations to rational cognitive processes. Freud himself would agree with me here, as he defines severe narcissists as, frankly, in his view, untreatable. I'm not so sure. I'm too early in my career to tell. But also certainly lacking concern for others. Malignant narcissism is on the rise in society, and clinicians must be equipped to treat this aspect of the typical individual, no less in people who are diagnostically narcissistic. To put this in epistemological terms, just a fancy word that means the manner through which you acquire knowledge, modern society has veered very much toward Epicureanism, the focus on gratification, and treatment therefore cannot now be conceived of as an additional gratification of desires. People are already doing that rather wantonly, though patients will seek that. One of the evidence-based treatments for borderline personality disorder is called transference-focused psychotherapy. It is, of course, no surprise to any analyst that a prerequisite condition for this specific analytic treatment includes protecting the frame within which treatment resides. The patient must have a job. They must show up for sessions. They must pay the bill. Anytime these things are broken, the therapist focused on the transgression and does not let it go. Obviously, these authors understand the moral conundrum that actually defines borderline PD. This is a very important point. Most therapists think that borderline patients are simply hapless products of trauma. Many of them, of course, have been traumatized. But the present condition involves a host of transgressive, enraged, and destructive effects on other people. Put most succinctly, the way that their mind is interpersonalized occurs through a moral prism, as is the case for all people, and specifically through an avoidance of responsibility, a projection and disavowal of shame and guilt, and a destructive envy meant to defend against dependence on the analyst. The modern general clinician unfortunately lets these things play out, become acted out, and does not view them as behaviors to be confronted. When patients say don't pay their bill, when really absurd interruptions occur to very normal confrontations, when sessions go missed to excess, the modern therapist is likely equipped, I should say geared, to have a completely passive avoidance of what these things really mean and what to do about them. I think a lot of therapists now are afraid of cluster B people, frankly. And this, I fear, and I would argue, is actually an immoral fear, because society is ailing as a result of our collective failures to confront people with severe pathologies.